Hello and welcome back to our series. We're grateful you're here. I'm David McConkie and I lead the Bladder Cancer Institute here at Johns Hopkins. We hope you're enjoying the beginning of the fall. As you know, we are always expanding our educational offerings, including our growing collection of programming led by Drs. Armin Smith and Jeannie Hoffman-Sensis, and the program team members Pamela Getz, Samantha Rockler, and Stephanie Cooper Greenberg, specifically tailored to the experiences of women with bladder cancer. We've got one coming up soon. Stephanie will introduce it to you later. And also, please see our website for more information about the next virtual women's group. Additionally, we've been working with our clinical providers to assure our GBCI front door for care is easy to access. We have two email addresses, bladdercancer@jhmi.edu, and a more specific email for upper tract urothelial cancer patients, utuc@jhmi.edu. As always, you can find our updated programming and useful resources on the web, including a new one-page bladder cancer patient navigation aid designed to help our patients understand the complex relationships between our unique teams and departments across the GBCI. You can download a copy from our website landing page or email us at bladdercancer@jhmi.edu to request this valuable tool. Always grateful to Stephanie Cooper Greenberg for creating our latest newsletter, which is available on our webpage. Or please reach out to us directly for a copy. Stephanie is working on our next newsletter, which will be coming up later this winter. While on our site, I encourage you to take a look at our previous Grand Round series that are all viewable through our YouTube channel. Please also mark your calendars to join us next month on November 19th as we welcome Clinical Director of the Division of Diabetes, Endocrinology, and Metabolism and Medical Director of the Metabolic Bone and Osteoporosis Center, Dr. Kendall Mosley, who will share insights into how patients can keep their bodies strong given a diagnosis of cancer. Again, more information for all of our programming can be found on our website. Google Greenberg Bladder Cancer Institute. And if we can help you directly, we are only an email away at bladdercancer@jhmi.edu. Today, we have an important cadre of expert nurses to share their professional insights and experiences related to the caring for bladder cancer patients and their families. As many will agree, nurses are the connective tissue of comprehensive bladder cancer care. From pre-op to post-op to systemic therapy, I'm grateful they're spending their time with us today to share their unique insights. Our co-founder, Stephanie Cooper Greenberg, and I have asked them to share more about themselves specifically, but I'm going to give you a short introduction now. Rhonda Sewell is an expert nurse who cares for patients with ostomy care needs. Debbie Schwartz is an expert oncology nurse with strong skills in surgical oncology, infusions, and clinical trials. Stephanie Russell is an expert nurse practitioner, board certified in adult and geriatric care of patients in the urologic oncology space. I'm grateful to have them all with us today. I'll turn it over to Stephanie and our panel. Just a reminder, please ask questions in the chat function, and we'll have a specific question and answer period after their panel discussion. Stephanie?
Well, hi, everybody, and thank you for we hit the jackpot today because originally we were going to only have the fabulous Rhonda and Debbie, and then we inherited Stephanie too. Debbie was supposed to go to a conference in Madrid, and somehow that got thwarted, and she got to come back with us. So we are so grateful to have you. It's always been the unspoken knowledge that nurses and nurse practitioners and those who are the helpers in this long bladder cancer journey are really the rock stars who help patients the most, interact with patients the most, have the most valuable information, spend time with their hearts and their souls, really care in such beautiful ways. When my husband was undergoing bladder cancer, I love the nurses so much. I could have stopped right there. So we just wanted to have a program to actually mine your incredible knowledge of what happens and what patients go through and tips for patients. And you see it all. And yet it's high time we recognize you in the remarkable work you do. So we're going to start off with our beloved Rhonda Sewell, who is a
Ostomy nurse.
and David,
Been a
we
long day.
need to learn the term, but we're a little embarrassed about you because you
Yeah.
clearly don't, you need to get out of the lab and into the clinics. Okay, honey.
No, stop
But
reading and start thinking.
okay, but Rhonda is a world expert is particularly for bladder cancer patients in ostomy care and everything about bladder cancer. She is in the clinic. I've seen her there. She's been with us for a long time. I'll have Rhonda introduce herself and explain what she does and how she does what she does and how you ended up in urology. I think that's really fascinating, your journey, and also anything you want to share in terms of how you care for your patients, tips for them, and knowing how difficult a journey it is, what you recommend or suggest. Be mindful too that bladder cancer is among the most followed cancers out there. So I think you see our patients with great frequency and probably form strong bonds with them because you see them quite often. Initially, I imagine every 3 months and every 6 months and over the years that you get to really know your patients. I can't think of a better person to come to a clinic to see than Rhonda. So with that, Rhonda, please share your story. Tell us how you chose urology or how it chose you and the specialty care that you deliver so beautifully to patients every single day. So please go, Rhonda. And then we're going to flip it over to, I believe, to Debbie and then to Stephanie to share their equal experiences and how you all work together so seamlessly. So let's go. Take me away, Rhonda. Help me, Rhonda.
Well, thank you so much, Stephanie, for that nice introduction. My name is Rhonda Sewell. I am a wound ostomy nurse specialist, and urology has been, I guess, my patient population for maybe about 4 years now. I started out, I've been a nurse now for 35 years. I worked at Hopkins for 22 and a half years, moved away for 4.5, came back, now have been back for 8 years. When I came back, I wasn't sure what I wanted to do. So I just decided to come back through the Hopkins agency, work some different units, but found out that there was a need for our wound ostomy team. So there was a need. I had a desire to help. And so here I am 8 years later doing wound ostomy care. I started, I think, Joanne, I don't know if you all know Joanne Walker, but she was our ostomy specialist for the urology service for many years. She retired, and when she retired, I took over the urology population. And this bladder cancer journey, it is a journey for our patients. Sorry for all these ums. I started working with the patients, and we actually have a really nice team, urology team here at Hopkins, our surgeons. We have a whole ostomy team of nurses, wound ostomy specialists. We work with the oncology team as well, our nurse practitioners, our advanced practice. We all work together as a team. So what we do is we will meet with our patients before they have their surgery. All the patients are scheduled with an ostomy nurse. We discuss things that for them to expect after the surgery, because the patients are so overwhelmed, they don't know what to expect. And we just become friends. We meet with them. During our meeting, we discuss the actual procedure, what's going to happen. And for the ostomy patients, they're going to have the cystectomies. They're going to have an ileal conduit with a urostomy. So then they have to learn how to care for that urostomy. And it entails a whole lot of things. We have a discussion about, hydration. They have to keep themselves hydrated after the surgery. Some people have a really hard time drinking fluids now, like prior to the surgery. So it's really important for them to drink after the surgery. So we talk about fluid and hydration. We talk about clothing because it's a whole lifestyle change for them. We discuss mobility. They have to move around, they have to walk in order to get the bowels to function again. Because there are complications sometimes with this procedure. So we meet them preoperatively. We move on to the hospital. We go into the rooms. We teach them how to take care of themselves with a urostomy. We show them how to actually do a pouch change. We have a whole session with them. And all the things they need to know about how to take care of themselves. Well, then there's what we call continuity of care. We then will follow up with them in the clinic post-operatively. And we actually establish a bond with them. We give them contact information. And I know all facilities work differently. They're ostomy nurses with their patients, but we actually give them contact information so that if they have questions when they discharge, they can contact us. You know, sometimes a lot of our patients are out of state. So if they have questions about the skin around the stomas or anything about their pouching systems, they can email us. You know, sometimes they can send a photo of what the skin looks like, and we can kind of help them troubleshoot over the telephone so they don't have to make that long travel back to the clinic. But they're always welcome to contact us. And if they want to be seen or need to be seen, we'll get appointments made for them to come in and see us. So it's a journey that I really enjoy working with our patients. And believe me, we all, I think, become family after getting together and going through this whole process.
Wow, that's beautiful. It's a very stressful time, I imagine, in most people's lives. I kind of have that, learned experience having been my companion to my husband when he went through it. But it was absolutely, completely mind-bendingly overwhelming because you can't even imagine like you're going to do what and remove it. This was bladder removal. I mean, we're at this, that's exactly kind of where the space we're talking about right now, but it's really hard to wrap your head around. And I imagine patients come to you very fragile and very overwhelmed and don't even know what questions to ask because they can't even, it's completely overwhelming. I don't even know how to say it better. What kind of questions, or number one, how do you help patients sort of cope with something that is so big? It is a very big surgery, and it's also a very big concept to wrap your head around that, it's time to make a big life change and maybe remove the bladder that's not working, that has cancer in it, or that's not working anymore, and your life will be better, although, it doesn't seem so at the time. How do you counsel your patients through the very difficult psychological aspects of this? And then I'll ask them more about what great questions you would suggest that they ask, because you know what you can tell them, and it might be helpful to have a slate of questions that they should be asking you. So the psychological component of like facing a very significant, almost life-changing surgery, which it kind of is. It's done very successfully and so forth, but it's hard to wrap your head around.
So for one, I think my approach with my patients is such that when they come in, they are overwhelmed. And a lot of things that I even say, I know they don't hear it because there's so much going on with them. And then they're getting prepared for the surgery. But first, I just have like a calming effect. And we just sit there and whatever they want to talk about, I allow them that time just to say whatever it is that they have to say. I hear a whole lot of information from the patient. I actually hear the patients. And I think just the fact that even though they have a lot of questions, and what I'll say to them is, you may have questions, but let me talk to you first. I may answer every question that you may have. And honestly, by the time we're finished with all the information that I give to them, they're like, well, you answered that question, you answered that question, you answered that question. I'm pretty much answering all of the questions that they may have because of the detail of the information that I give them. And like I said, we discuss a lot of things. We discuss, you know, what to expect after surgery. Like, you're going to have to get up. You're going to have to walk around the unit. They want you moving. They don't want you just sitting around. You have to make sure you're drinking. You need protein for your healing after your surgery. So we know that you may not be able to eat right after your surgery, but there's protein shakes that you can drink. Your body needs protein. So you're going to have to maybe drink some protein shakes. And a lot of the surgeons are going to encourage you to do that. So I'm giving them that information before they even come in and have the surgery. We talk about clothing because the stoma, you can't wear anything directly over that stoma, like your belt. That stoma has no feeling, there's no nerve endings. So they can cause trauma without realizing it. So we discuss clothing. And a lot of people think they have to go shopping. I say, no, use what you have. See if you have to make any changes. If not, a lot of times you can just use what you're using right now. So, but for our women, if they want to go shopping, I tell the husbands, yes, she's going to have to go shopping after the surgery, just to kind of lighten the mood, So, we discuss things to, report complications, skin irritation. We tell them what not to use that's going to cause problems. And we tell them what is going to help keep a good seal. And with these cystectomy patients, the main thing is finding that pouch that keeps that seal without leaking for 3 to 4 days. And once they've done that, because that's the hardest part of it, is some patients have a lot of problem with it leaking, and it becomes very frustrating for them. But we work with them and we tell them there's ways of working with it. You try something, you're going to go through a whole trial and error period. You try something, it's not going to work. We try something else. But stay in touch with us. Let us know what's happening. We can work you through it, help you through it. But a lot of it's so much information I give them so that they don't really have a lot of questions once we're done with our meeting preoperatively. But we reinforce everything because they don't hear it all that
Right.
first meeting. When we say them again, we say it, the surgeons say it. So the more they hear it, it'll start to click. And even with the information we give them postoperatively, I tell them to read it. I said, and you'll probably forget it because we give them another folder of information after the surgery. We try not to give them so much at one time. So we give them some during the pre-op visit, some during the surgery, right after the surgery. And then we kind of reinforce it when they come back to the clinic. But a lot of times they'll read it, but they have anesthesia in their system. They have the pain medications in their system. They don't remember. So I say, once all of it is out of your system, read it again. And then down the road, you've been doing it for a while. Read it again, it'll all start to make sense. So.
Well, you're a blessing because you're explaining things that, the fine details. I mean, someone has a diagnosis of bladder cancer, that's a total shock to the system because most people have never even heard of it still. And then they have maybe gone through other treatments and, the whole boogeyman surgery is hanging out there. And then all of a sudden there's a day where they're seeing you and it's really going to happen. And there's a lot of preoperative things that people have to go through. They have to have what is some kind of a preoperative evaluation and a lot of paperwork, I remember, and a lot of a doctor visit to make sure everything's in good shape, and then they see you, and it's a long journey and a very stressful one to get to the operating moment, and then it's quite a long surgery. Can you explain to our patients what ERAS is? That's something I remember being given a booklet about, like, you're going to have a surgery, and this is a system that has been developed called enhanced recovery after surgery. Can you explain briefly what that is? And it's very much in line with what you were just talking about, but it's actually a whole field of study that patients recover more quickly if you implement these sort of protocols, get up and walk and drink a lot of Gatorade and other things. Can you share what that is? And it's not just for bladder cancer, it's surgery in general, right?
Surgery in general, yes.
Yeah.
So yes, that program, even preoperatively, it used to be years ago that you couldn't eat or drink anything after midnight prior to your surgery. But with the ERAS program, they're now having patients drink, or it's been going on for years, Gatorade 2 hours prior to the start of their surgery, because they want them to have some electrolytes on board right after the surgery, because we realize they're losing a lot of their electrolytes. So to try to keep a balance, they're having them drink Gatorade. And it's like, I can drink that. It's not going to make me sick, but they've been doing it for years and it's actually helping. And there's pathways that they have in the hospital. Patients has to get up, they have to walk, they have to move around. And it's a pathway of, they have to learn how to take care of themselves. It's all a part of the teaching process. And we even use our nurses to help teach the patients the care that they're going to need, after they're leaving the hospital. But I think with this program, it's even a limited amount of days that they stay in the hospital, because they stay on the pathway. So it's an earlier discharge, because they're kind of having an earlier recovery after their surgery. So they're not staying in the hospitals as long as they used to.
Would you say, it's dehydration is not a good thing, and also it helps when you're hydrated, it helps stimulate your system and get you back everything moving again, interior and exterior. Is that correct?
That is correct. Yes, because if you need to be hydrated. Dehydration is going to get you back, even after you discharge, it's going to get you readmitted to the hospital, because you really can't move. You can't do anything because you've lost all of your, you need that hydration and even to be able to function, because patients feel really weak and they're tired and they really can't do anything. So yeah, they really need to keep the hydration after the surgery.
How far after surgery do they typically come back and see you? Is it months after, or?
No, it's usually 2 weeks from the day of their surgery that they come back for their post-op visit. So if they're discharged, say today, they're coming back on the 15th. So it's they're only home like a week or so before they're coming back.
And then are you happy to see them and they're happy to see you?
Oh, yes. Yes.
You're on the other side of it.
Yes.
So tell us about that.
Well, I'll be honest, once they have their first meeting, they're more kind of relaxed about it, because they're like, okay, this makes me feel better because now I know more about what to expect. But prior to meeting with us, they really don't know. But no, when they come back to clinic, some of them have already changed their own pouches. A lot of patients are intimidated and they feel really nervous about it. But what we do is we arrange for nurses to come to their homes, to work with them, to help them to learn how to independently care for that stoma. And they're actually putting their hands on it and getting more experience. The more they actually practice and do it, the more comfortable they'll become with it. So, and then when they come back, I literally had a patient cry her entire pre-op visit. And she said, but Rhonda, if you say that there's other people that can do this, then I know I can do it. And she, for a long time, she wasn't doing it. And then when she came back to see me and she said, Rhonda, I'm doing it by myself. And I was like, I am so proud of you. So it actually happens. It takes time, but when I see the patients and they don't look like they're patients, they're doing their thing, it makes us both happy. So
thank you, Rhonda.
I actually see it.
I can't imagine what a comfort you are, because you're giving that sort of those tips and that human comfort that, and you're spending time and hearing, understanding their anxiety. So it's a big part of it.
And I'll say one more thing. There are some patients that have a really hard time dealing with it. And I do let them know that it is okay to talk to someone. So some people will get a therapist to talk to because they have such a time coping with it. So not everyone handles it well.
Well, it's life-changing.
And it's a permanent thing. It's not temporary. It can be reversed. It's permanent. So yeah.
Well, thank you, Rhonda. Help me, Rhonda, and you've helped them. Great. Now we're going to switch over to, I think Debbie next. Do I have those sequence right? No, to Stephanie next, right? Okay. And you're all a team. So tell us, Stephanie, and thank you for coming and thank you for being part of this. We're really grateful to have recruited you, and now you're part of the family. And I know you already work together, but explain where you are in this sort of trajectory and in the journey. We've heard from Rhonda, and tell us about where you are in this whole long journey that we all share. Almost like everyone with bladder cancer is a family member, and you are our helper. So thank you for that.
Of course, yes, happy to be here. So yes, I'm a nurse practitioner, like Dr. McConkey was saying. I work in adult gerontology. That's what I'm board certified in. Have worked for as a nurse overall for 12 years. I worked for 10 years at University of Maryland as an inpatient nurse, as a research nurse, as an infusion nurse, all within oncology. And then I came to Hopkins in 2023, and I work with the medical oncologist. So as a nurse practitioner with the medical oncology team, I work with Dr. Hoffman Census, I work with Dr. Noah Hahn, Dr. Burles Johnson, as well as the surgeons. Like you were saying, we're all a team, so we all work together. But so essentially, when a patient is diagnosed with bladder cancer, oftentimes they undergo what we call systemic therapy. So that could be medication either given intravenously, so through an IV, or with oral medication pills. And so, as everyone's been alluding to, this can be a journey. So, every cancer diagnosis is different. And so some patients get chemo actually prior to their cystectomies. So I may see patients even before they get their surgery. Sometimes you get chemo or immunotherapy. So those are types of treatments for bladder cancer. You can get it prior to surgery, or you can get it post-surgery. So I will see you pretty much throughout the whole journey. And typically, I work with the medical oncology team. So I think sometimes people can get a little bit confused between what a nurse practitioner and a nurse do. Essentially, we all are, specialized in part of this team, but a nurse practitioner, it's within my scope to diagnose, order medications, order imaging, prescribe medications. So I'm essentially an extra helping hand for the provider, the doctor. So you may see me in combination with the doctor. So one week you might see me, the next week you might see the doctor, so on and so forth. You might send in a message, and I may answer in conjunction with the medical oncologist or the surgery team. I'm an extra hand to reach out to Rhonda, or send you to the right person. If you have a question and you're in the middle of your care and you don't really know who to reach out to, I think that's kind of the beauty of nursing, is that we're always there for the patients to offer any extra support that is possible. So, a typical day for me, I would see a patient in the clinic. It might be the day that they get chemotherapy or immunotherapy. I would go over their lab work with them, their symptoms that they're experiencing, help them parse out if it's a side effect of their medication, if it's part of their cancer diagnoses, give them tips to help manage these side effects, if they need extra help with medications, or if they get imaging and they need help interpreting some of the imaging results, because that can be anxiety producing for patients. So I'll go through imaging with patients, I'll go through lab work, and really just help them with whatever needs they have, and make sure that the journey is as smooth as possible.
You see patients who maybe are not candidates for surgery, as well as not everyone ends up. I mean, the whole emphasis really is bladder preservation. I mean, that is what the overarching goal is not to have to get to that point. But sometimes it's most appropriate, standard of care. But do you see patients early with non-muscle invasive disease, I imagine, through the you know, assuming it can stop right there. It's almost like a crossing the street in many ways. I mean, you intersect with urology, oncology, they dovetail each other. Um, um, can you talk to us a little bit about the chemotherapy experience? And believe it or not, when in the last 10 years, um, you know, 10 years ago, there was no immunotherapy. So this is fairly new in the grand scheme of medicine, you know, since, you know, time began. So can you explain what the chemotherapy process is and now this new immunotherapy process? Many patients or people tuning in may not have had the benefit of receiving immunotherapy because it just simply didn't exist. And then the third part of it is that there's so many new um, combinations and drugs and all that. How do you know how to choose?
Yeah, so yeah, it's a big question. Like I was saying, every cancer diagnosis is a little different, and we're so fortunate now to have so many different options. And really, because there are so many different options, you really do need to work closely with your medical oncologist as well as a surgical oncologist, perhaps even a radiation oncologist, like you were saying, bladder sparing. Sometimes we use radiation and don't go for the full cystectomy, you know, depending on what the patient wants. So, you know, a myriad of options. But with chemotherapy, you know, typically, Dr. Hoffman Census, Jeannie, one of the medical oncologists I work with, has a very good analogy that she likes to use. And Debbie's shaking her head because we've all heard her in the clinic tell patients this, but it's very appropriate that getting treatment for cancer is like a road trip. You know, you have a destination, which is to defeat the cancer. And we are all on that journey with you. And there will be bumps in the road, and we will take alternate routes. And our job is to help you with these issues that arise. So, you know, I think people get very nervous when they start treatment, whether with chemotherapy or immunotherapy, because you know, you hear about the side effects, fatigue, nausea. You may already be experiencing these symptoms from your cancer diagnoses. So people can have a lot of anxiety about what will I experience. So I think that a big tip that Debbie and I have discussed before for patients is write down any questions that you have. Make sure to write it down on a piece of paper so that you can ask, you know, what are the side effects I'm going to experience? I mean, we're going to go over everything, as Rhonda said, and we might answer all those questions for you, but write down the questions that you have. Bring someone with you so you can have an extra ear. You know, like Rhonda was saying, it can be very overwhelming to get all this information at once. So it's helpful to, you know, we'll give you written down information, write things down as you find appropriate, and bring someone with you. So that, you know, you can have an extra ear to help just parse everything out. But a lot of anxiety to start, but usually once things get started, we get a few of those bumps in the road smoothed out. You know, things usually go well for our patients with a little bit of help. So you know, immunotherapy, I think people think that you know, it's brand new, and it's very appropriate to ask about it. A lot of patients, you know, they hear about these things, whether on TV, you know, a friend got immunotherapy because, you know, in my experience, I've worked with lots of different cancers, you know, breast cancer, lung cancer. Immunotherapies start being used across cancer. So it's very common to have a friend or a family member who's gotten immunotherapy. And I think that everyone's experience with systemic treatment is different. So, you know, it's very appropriate to say, hey, I heard about Keytruda or Opdivo on the television or through my friend, and ask if it's appropriate for you. You know, we have no problem going through different treatment options with you and what's most appropriate. You know, obviously, we're going to recommend what is most supported by research and what we think is best for you and your preferences. But, you know, these things can always be discussed. So I always encourage patients to ask questions, and of course, ask till you feel like you understand it, understand the answer.
Great. I have a specific question. Many of our patients come from out of state, so they're not in Maryland. And when they're prescribed, say, a course of chemotherapy, can they do that chemotherapy in their hometown where they live? And how does that work in terms of you don't necessarily have to get on a Southwest Airlines flight and come have chemotherapy. It can happen anywhere. How do you coordinate that care when someone is actually from out of state?
So we have lots of patients who come from out of state. So, you know, if you want to just come in for a second opinion, you know, meet with one of our medical oncologists, see what their opinion is, and then, you know, we can discuss with the medical oncologist you're working with in your home state. Sometimes patients, if they have family members or friends who live in the area, you know, if they have the means to get lodging here temporarily, you know, sometimes people will come for, you know, we've had a few patients who live in West Virginia, you know, they'll come get an Airbnb for a few days around treatment, get treated, and then go home for the week. But it is a lot of coordination, and we try to have people understand that, you know, the most important thing is if you get treated with us and then you return back to your home state, is that you have some, you know, emergency plans to be treated either with fluids or to be seen locally, and we can certainly talk with you know, local providers that you have in the area, but it's very common to either come weekly, like immunotherapy can be given every 2, every 4, every 6 weeks. So you know, depending on what your treatment plan is, you know, we have lots of patients who are who don't live in the state of Maryland, and we, you know, we can figure it out somehow or some way. It's usually no problem. And now Hopkins itself, I mean, it's really amazing how you know, there's lab cores everywhere, there's imaging everywhere. You know, you can get a CT scan in West Virginia and then they can send it to us and we can have our radiologist read it and compare it to a scan that you got here. You know, these are just some options of things. So you know, with technology, you know, things are getting a lot easier. You know, telehealth, I mean, there are some laws prohibiting some things, but, you know, telehealth are options as well. So technology has helped with making that practice easier.
Fantastic. A question about chemotherapy in general. It's a cycle of a few months, would you say, versus say, well, how long is the typical sort of course of chemotherapy? I know it's a generalized question, but
Yeah, I mean, there are some kind of standard chemotherapy regimens that we give to patients that are given in other cancers as well. You think of some chemotherapies called like cisplatin, gemcitabine. These are common medications that are given in several different types of cancers. The way that it's typically given is in cycles. So, you know, sometimes you'll hear this jargon that we use that, you know, cycle 1, day 1, cycle 1, day 8. And it sounds very confusing when we first start using it, but eventually people start to get it down. And we usually give you a schedule to make it easy. But yes, it's not like a one and done type of thing. Chemo is a long process. You know, if you are getting what we say like 4 cycles, which is a very common practice in bladder cancer and muscle invasive bladder cancer, is to get 4 to 6 cycles, which are given over a 3-week period. So, you know, that could be 3 to 6 months of chemotherapy before getting your surgery. Or if you get surgery and then we give you chemotherapy afterwards because you have some residual disease or high risk of recurrence, when you get your surgery, then it could be another 4 to 6 months. Immunotherapy, we often give a year. Patients with more invasive disease or metastatic disease can be treated their whole lives. I mean, it can be very daunting, the concept of these timelines. So that's why every patient we go over with to make sure that they understand what an accurate timeline of everything can be. But kind of a complicated answer there. Yeah.
No, that's very helpful. And immunotherapy is administered typically every few weeks, is that it? Or not so frequently? Is that
Right,
correct?
exactly. Yes. Typically every 2 to 3 weeks sometimes. I mean, there's different regimens for every different medication, but chemo can be given, typically once or even twice a week sometimes for 2 weeks in a row, and then you might have a week off, and then that might be one cycle, and then you restart the same process after the week off, and that's your second cycle. So this is very standard across cancer.
Very long road trip, right?
Yes.
It's years worth, but the point of that is not lost. I mean, I think can be lost is that all the stuff, as awful as it can be, does work.
Yes,
And
yes,
the goal is to keep bladder cancer in abeyance or eliminate it. And then sadly with surgery, which is, mind bending, that can take care of it too. So the goal is to stop the cancer, and there's a lot of stuff you have to do. And so what I'm really getting at is your patients are with you for a very long time, and you get to know them, I think, quite well.
Yeah. Sometimes, we see the patients if patients want, they can get as much support from us. They probably will be sick of seeing and talking to me sometimes. But I'll talk to you every week, every day if you'd like, to help you get through it. For your 3 to 6 months of chemo, because it can be difficult. But like you were saying, the point is to get your cancer under control, to treat your cancer. So we do what we have to, and luckily, with all the experience that the medical oncologists have, that we have, we're very good at controlling symptoms that are related to the chemotherapy or immunotherapy, so that you can live as normal of a life as possible while you're getting treatment. That's our whole goal, is so that you can see your loved ones, do what you like to do, even while you're getting chemo.
Keep working as well, right?
Exactly. Yes, some people work. I mean, some people choose not to work, but if you want to continue working, we will do and support you in whatever way we can. Like Rhonda was saying, like staying hydrated, like we have extra support with the urgent care at Hopkins. We have the infusion center. Debbie and the research nurses are very helpful as well, and just making sure that your needs are met while you're getting chemo or immunotherapy, and making sure you stay and feel well. And a lot of our patients are able to continue doing what they like to do, continue working while they're getting treated.
Well, thank you for that. We're going to go to Debbie, but I just want to say, like, we hope that all that remains after all this really hard work, the whole journey is a very long and difficult one. I've witnessed it. It takes years, and it's stressful, and it's uncertain, and there's so much to it. But then there's a day you remember, oh, that Rhonda, she was awesome, and that Stephanie was amazing, and I don't need them anymore in my life, and I'm well, and I'm have a high quality of life, and I'm living my life, and it's in the rearview mirror. That journey is turned into a better quality of life journey. So I have a feeling that you are thought of very fondly, and patients do get to the other side of this. Clearly, I understand. I've witnessed that myself. So now our beloved Debbie, who is in a really fascinating space. Please tell us about what you do, and you're more on the clinical and research side and clinical trial side. what I would say about our beloved Dr. McConkey, who can't pronounce urostomy, we love him for that though, is, there's a whole rich research environment going on of discovery and this will to do better medically with better therapeutics or biomarkers to sort of predict disease and AI and organoids and all this incredibly cool research that Dr. McConkey is leading. And Debbie is at the intersection of how the patient and the research can translate to better therapeutics and better procedures and outcomes for patients. So Debbie, take it away.
So just to start off, I have been a nurse for almost 20 years. I actually came into this from this is a second career for me. I was in the financial world. And while I was getting my MBA, I met a lot of people that were the bean counters, as I like to call them, in healthcare. And I thought it sounded cool, but then I decided that I'd rather be on the medical and personal end of things. So I went back and I took all the sciences that I avoided like the plague while I was an undergraduate the first time, and then went to nursing school. And so I spent almost my entire career in oncology. I was surgical oncology for my first 3 years because I wanted to get a med surg experience. And then I spent 12 years doing infusion, giving chemotherapy. I was the first person at my clinic to give immunotherapy, which was really cool thing. And then for the past almost 3 years, I've been doing clinical research specifically for bladder cancer. So I actually work with the urology clinic as well as the medical oncology side, because there are certain regimens that include both therapy given through an IV systemically, as well as what we call intravesically through the bladder. So I kind of bridge the gap between both of them. So, I mean, basically, I've become involved when an oncologist, either an oncologist or the urologist, says, "Hey, I have this patient that I think would be appropriate for a certain clinical trial." And so each week we meet as a group, all of the urologists, all of the medical oncologists. We meet as a group and we present what clinical trials are available. And at that point, I'll get a name, and then I reach out to the patient, and hopefully most of the time the patient is expecting my call, and they know that their doctor wants them to consider a clinical trial. So I'll introduce myself, and I'll send a consent through email. And the nice thing about the consent is it puts everything in layman's terms, almost the entire process, what the research is hoping to accomplish, and what the patient's role is, what is what's covered, how, one of the fallacies in research is that you're on a research trial and the drug is free, everything is free. And that's not necessarily true. A lot of what's considered standard of care is billed to your insurance. So I find it very important to make sure that a patient understands that there are certain aspects of a clinical trial that, yes, are going to be free. Maybe the drug is free, but there are going to be things that are going to be billed to their insurance. And if they haven't met their deductible, they are going to, get a bill. The last thing I want is for somebody to be taken aback. Oh, I thought everything, that everything would be covered, but that's not necessarily the case. But more importantly, my role is to make sure that the patient understands, one, that any clinical research is always optional, that we are, you can sign consent for a trial and then decide, no, you know what, I thought about it and I don't feel comfortable. And that will in no way, shape, or form affect how they're given care. My favorite part of the whole clinical research process is I basically am acting as a navigator. And I love that word. I'm walking a patient from consent all the way through treatment, all the way through survivorship, which is a wonderful word. And I'm kind of the first person that they can contact with any issues at any point of the process, whether it's during the consent process, during screening, which includes lab tests, radiology, all those types of things. I'm there to answer any question. And then during treatment, I'm there, if they have a question and they feel more comfortable contacting me first, I will answer any question. And if I don't have the answer, I'll make sure that I get it and that they are, that a patient is put in contact with the appropriate person.
Are patients interested in enrolling in clinical trials when they're recommended specifically for them? Is it, I've been under the impression that it represents, progress in something new and maybe avoiding something else, meaning surgery. If you can be in this trial and see how it works with a valid, these are usually phase 2 or 3 trials, I imagine. Or
Some
maybe,
are phase 1.
Yeah. Which I'll have you explain in a
Right.
second. But is there enthusiasm about joining a trial?
It depends. I mean, I've had some patients that have been on multiple clinical trials. And I've had patients who, their first reaction is, I don't want to be I don't want to be the guinea pig. And that's certainly understandable. And so it just, some people are enthusiastic and can't wait to, as they put it, be a part of something that spurs, that could save somebody else from having to go through what they're going through down the road. And then I have patients that, they hear the word clinical trial and they are absolutely not interested. And that's fine as well, of course.
Can you explain phase 1, 2, and 3 from the patient's perspective? What does that, I mean, I know that's a huge question, but what specifically does that
So
entail?
phase 1 is basically looking at the safety of the drug, is making sure it's the first time that the drug is being tested on humans. And it's, we're just looking for, what we're looking at adverse effects. We want to know what they are, and how they're handled. And then phase 2 and 3, it moves into, so once a drug is established that it can be safely given to people, then the next steps are to figure out what the appropriate doses are.
Oh,
what's how much can we give, or how little can we give and still get the same result?
And they're comparative typically.
Right, exactly. The one builds on the other. If a drug doesn't pass through phase 1, it's never going to get to phase 2 or 3.
Explain phase 3. Those tend to be what? It passes phase 1, and then you have phase 2 where you figure out the dosing, and then phase 3 is
just reinforcing that that the drug is safe at a certain dose. It's really the last step before it gets to the FDA. So it's showing what that it is actually kind of better than what the standard of care is.
And I understand those are quite large trials.
They're huge. Yeah, they're very large trials.
So a patient at Hopkins who's on a clinical trial may be on a trial that other people in the country are on as well, correct?
Right. And there's some trials that are industry sponsored that are all over the country. And we're just one of the many sites that the trial is being conducted. And for example, what Stephanie was saying about the, trying to help patients that are out of town get the same care. So a patient may look at, go to clinicaltrials.gov and see a trial and see that it's been giving at Hopkins. That's the first thing that they see. So they'll contact us and say, I want to find out about the trial. And then they'll say, well, but I'm living in Kalamazoo, or maybe they're living in New York, but maybe Sloan Kettering is also giving doing the trial, or we'll try to help them find a place that might be a little bit more geographically palatable to them.
What about the reporting? So are patients on a trial? This is a general question. Very monitored for side effects.
Oh, absolutely. No,
how is that done? Are they talking to Debbie? Is it surveys? Is it
so some of it is electronic surveys that are done, some of our paper surveys, but each and every time a patient comes in for a visit, I'm asking them about their side effects. I'm asking any new side effects, any new medications that they may be taking, because that's also important. There's some medications in a clinical trial that are prohibited. And we try to kind of know about that before they even go on trial. So if there's
a different drug for a different purpose,
that's contraindicated. So we want to know. One of the first things that I do when I meet with a patient is even before I go through their entire medical history, and then I review their medical history and their list of medications to make sure that I have the most accurate picture of what they're taking.
You're their clinical trials coach and de facto coach, I bet, right?
I that's what I try to be. I want to be their coach. I want to be their support system. One of the things that Stephanie and I were talking about, especially with side effects, is, and this is straight from the mouth of Dr. Hoffman Senses, is we never want to hear about a new side effect when you're walking in the door for your treatment day. We should have heard about that. Nobody should be walking in and saying, oh, I've had diarrhea for 3 weeks. Because if you're on immunotherapy, that's a big deal. That can be what we call a dose limiting toxicity, meaning that, that could be a reason that we could have to stop drug.
Wow. For a patient who has adverse side effects, who makes a decision to ask them to not be on the trial? It's just too much. It's not really working for them, or how does that decision made?
Well, obviously it's a conversation with their provider, and the protocol kind of lays out what needs to happen with different side effects at different levels. There's something that we use called the CTCAE, and I'm not even going to try to remember what it stands for, but it basically is, and it's used across cancer to label side effects at different grades of side effects. So if, let's say, a person has a rash, if it's a rash, if it's a rash that you can put a little hydrocortisone cream on and it goes away, then it's considered less severe, versus you have hives from head to toe and you're itching so bad you can't even think. That's a different story. And most likely we would hold drug until that rash is resolved to a lower grade. And again, it's all laid out in the protocol in terms of what needs to happen if a side effect gets to a specific grade.
Well, I want to thank all the patients. Thank you, Debbie and Stephanie and Rhonda, all the patients who are in your care or on this long road trip journey, but also those who have agreed to be part of the clinical trials, because I'm going to ask David McConkey now. Clinical trials are really how you come up with new therapeutics and progress. And so, David, can you explain how it's so vital for research and for the future and for progress? How this is a whole system that is very symbiotic. I mean, from Rhonda coming in to see Rhonda or Stephanie, and then being in a trial what is the big picture like? How do clinical trials inform progress?
Well, I think that's a great pitch for our next session, where you'll hear all about skin toxicity from Jeannie and Alina. But yeah, I've been spending a lot of time today, part of my brain lapse earlier, designing the translational medicine session for our upcoming SWOG meeting. And going to go
It's a
and
cancer
attend the
meeting, everybody.
ECOG meeting too this
Okay,
year.
that's another cancer meeting.
And again, we've got tons and tons of really exciting clinical trials going on in all states of bladder cancer. It's a wealth that we've never had before. And
These
that's
drugs,
yeah.
I don't mean to interrupt you, but the drugs being tested, I don't like that word, eventually end up, if they work and the data shows it's working and it helped patients, overall survival or whatever the measure is, they become FDA approved and then they become available for people to use. Is
Yeah.
that
And
how it works?
I saw Noah was on this call, and of course he's leading his ADAPT bladder trial, which you'll all hear about pretty soon. Very exciting results coming out of that and a lot of other trials in non-muscle invasive bladder cancer, and lots of cool biomarkers. All kinds of things with urine we never thought we would be doing as quickly as we are now, and blood, when to escalate and de-escalate. That's a huge issue for people who are getting systemic therapy, and we've got tools now that Jeannie and Noah and Rusty are using routinely, looking at circulating tumor DNA. So it's great.
All about these fantastic nurses who are
Yeah.
really, because of you, the future looks bright. In the past 10 years, is it at least 10 new therapeutic drugs, immunotherapy drugs have been approved? There was nothing before, nothing. I mean, BCG, chemotherapy, that was 40 years. And then all of a sudden, 10 years, now there's just all these new things that are actually working. So we thank our patients for being brave and courageous enough to enroll in a clinical trial. We hope it helps them, of course, in their journey, but also you're really helping others. So, but without nurses, our NPs, our Debbies, our Stephanies, our Rhondas, I don't know where we'd be. You are the mother's milk of this whole process, and you comfort people and you answer their questions. It's like your little family. And of course, with bladder cancer, you see them and get to know them for very, very long periods of time. So with that, we can't thank you enough.
Yeah, and I'll just state too, you guys are the glue that holds our team together.
There's no
We
question.
really appreciate that.
Everyone's going to remember that Stephanie and that Rhonda and that Debbie. They may not remember, sorry, their surgeon's name, but they're definitely going to remember you. And they're looking in the rearview mirror, as my husband does very fondly. That's who he remembers, is the nurses who cared for him. And he also remembers the surgeons too. But you guys were it for him. He loved you, and he knows that you had his best interest at heart. So thank you all for joining us. Speaking about research, we have the coolest women's bladder cancer program going, and maybe the only one dedicated to women. It's Johns Hopkins Greenberg Bladder Cancer Institute. It happens at Sibley with our beloved Armine Smith, who is a surgeon, and Dr. Hoffman Census. They're both going to be speaking 1 month apart about their own research. So research is a big part of the Bladder Cancer Institute to create progress and better drugs, better outcomes, better for our patients. Armine will be speaking on October 15th about her very fascinating studies that she's embarked on. One of them has to do with BCG. We didn't really talk about that today, and how it affects your mood. Well, guess what? There's a correlation between BCG and depression. It's a real thing. It's a real science thing. Who knew? Well, she's going to be talking about a study that she's doing on the microbiome and bladder cancer. She's going to be talking about another study she's doing on surgical outcomes for women, which she's trying to improve upon, bladder sparing, organ sparing. On November 12th, Dr. Hoffman Census, back to Debbie's point, is going to be talking about a fascinating study that she has observed about a certain immunotherapy drug and skin toxicity, meaning rashes. It was sort of like that COVID thing. You get the COVID vaccine and you get really sick and you're like, oh, I feel awful, but it's probably working. you've got to have this sort of optimism that I've taken something and it's doing something bad to me, making me feel awful. But maybe that means it's really working in my immune system. Well, Dr. Hoffman Senses had a hunch that skin toxicity, these awful rashes, may be correlated to better survival taking a certain drug. And she's embarked on this fascinating and important and meaningful study. So on November 12th, she's going to be talking about that. You can Google it, or you can, we'll send you the flyer, but October 15th, save the time, and November 12th. And then on November 19th, we're not done yet, with Dr. Kendall Mosley. We're going to talk about urinary diversions and anemia and bone health. It's all related. And how finally the endocrine system is very much part of this whole other system. So she's going to explain a lot about how that is all connected. And then our last session for 2024 is with our beloved Lily Shockney, who's a remarkable nurse, navigator, expert leader in nursing, for oncology nursing. And we're going to talk about questions we should be asking, patients should be asking. Lily is a force of nature, not to be missed. And that will be on December 10th. So thank you all for this remarkable session. We love our nurses. We love our NPs. We love our Debbies, our Rhondas, our Stephanies. You do God's work, and we really thank you. So thanks, everybody, for joining us today. And thank you, David, for tolerating all these. We kind of jabbed and poked fun at you, but it's okay.
I can take it. Not the
Okay.
first time. A lot of support. Thanks,
Thank you all.
everyone.
Have a great evening.
Take care.